Good morning, good afternoon. Welcome everyone on behalf of the Columbia Global Centers of Amman, Istanbul, and Tunis. Welcome to this webinar. It is the latest of a series of events that the 9 global centers of Columbia University hosted in the recent months and that deal with the COVID-19 pandemic. And by the way, you can check our website to see previous webinars. Today, our panelists will discuss the issue of inequality in the distribution of COVID-19 vaccines, especially among vulnerable populations such as refugees or migrants. And there are millions of them in our region. But the inequality in vaccine distribution, we have to remind everyone, is also hitting supposedly non-vulnerable populations because of this now so-called vaccine nationalism. For instance, it's March 3rd, 2021, and I'm talking to you from a country, Tunisia, that hasn't started the vaccine campaign yet. So without further ado, I will give the floor to my dear colleague, Yanis Ben Amor, Executive Director of the Center for Sustainable Development at the Earth Institute and Assistant Professor of Global Health and Microbiological Sciences at Columbia University. Yanis will lead today's discussion. Fadal, sir.
Thank you so much, Youssef. I want to welcome you all to our webinar today entitled Equitable Access to COVID-19 Vaccines, Challenges and Solutions. So at the end of 2020, a rather dark year for humanity, we thought we finally saw the light at the end of the tunnel. There were several good vaccine candidates who were coming out of the pipeline. People were very excited about this news because all of them seem to have very good efficacy, particularly against severe disease and deaths. Ironically, around the same time, we also found out that there were now variants of COVID-19. 3 of them were of particular concern. The first one, B.1.1.7, was first identified in the United Kingdom. The second one, B.1.351, was first identified in South Africa. And then there was P1, who was first identified in Brazil. So why are these variants of concern? Is because they all have a mutation in a region of the virus that is specifically targeted by all of the vaccines that are either already out or under investigation in the research pipeline. So that is of concern because we are wondering, are these vaccines actually going to work? So after a few weeks of investigations on these new variants, we found out that they are in fact more transmissible. And in the case of the Brazil variant, it also evades natural immunity, meaning that if you had an infection with the original virus, let's call it the Wuhan strain, then you are not protected against the variant from Brazil. So that is of particular concern as we are now starting these mass vaccination campaigns. So the good news is that from what we know to date on March 3rd, it seems that all of the vaccines actually still work against these 3 variants. There is lower efficacy. In some cases, there is actually significant decrease in efficacy, but they still work. And so that's why it is so important more than ever to vaccinate everyone and vaccinate quickly. Vaccinate everyone means not just vaccinate rich countries and leave people behind, and within countries, not just vaccinate those who have the means and leave others behind. So just to give you a little perspective of how badly the situation is, so as of yesterday, March 2nd, 250 million doses were administered worldwide, 50% in only 2 countries, the United States and China. 75% of the 250 million were in 6 regions. So United States, China, and then you had United Kingdom, European Union, Brazil, and Israel. So this is not acceptable. And if we look at the African continent, so Youssef just said that Tunisia, the country that I'm from, did not start vaccination. Actually, only 5 countries in Africa have started vaccination at very low level. South Africa, Morocco, Senegal, Algeria, and Zimbabwe. So the mantra that you will hear a lot is no one is safe until everyone is safe. And I think this is extremely important. Not just rich countries, the whole world. This is an ethical problem, but it's also a problem to protect us all. So within the countries that have started vaccination, it is important to vaccinate everyone, including vulnerable population. So among the world's millions of refugees, there is a concern that many may be excluded from their host countries' national vaccine programs. or face added barriers to access due to a shortfall of COVID-19 vaccine supplies. And even in host countries who have started vaccinating refugees, those who are undocumented may remain sidelined. Failure to include vulnerable populations in their coronavirus responses will undoubtedly undermine a global recovery from the pandemic. So we are so fortunate today in this webinar to have three experts who are going to help us understand what are the issues and what their respective organizations may be doing to try to help solve some of these issues. So I'm going to call on our first speaker. So Dr. Ozge Kaman is a colleague of mine who works as a public health researcher at the Center for Sustainable Development at the Earth Institute at Columbia University. Dr. Kaman earned her medical doctor degree at Istanbul University and her MSc and PhD degree in public health at Hacettepe University in Turkey. She also holds a postgrad degree in health promotion from the London School of Hygiene and Tropical Medicine. Dr. Kaman has more than 15 years of experience in research and public health policy programs development for different vulnerable, disadvantaged population groups. And her current work focuses on research, advocacy, and training activities regarding the effects of the COVID-19 pandemic on the most vulnerable populations, including migrants and refugees. And today, she will tell us about the pandemic response and access to vaccine and give us a situation of her home country of Turkey. Ozge, the floor is yours.
Thank you so much for Yanis for the introduction. So I'll just try to share my screen first and then start. Can you now see my screen?
Yes.
Okay, thank you. So today I'll try to summarize the pandemic response and access to vaccines for the refugee and migrant populations in Turkey. And actually, as we all know, accumulating data show that migrants and refugees are disproportionately affected by the pandemic. And despite regulations and codes of practices for universal health coverage, and despite the efforts to include vulnerable or disadvantaged groups in healthcare, experiences show that healthcare is not always at equal distance from different subgroups of a population. We know that the virus itself does not discriminate, but social determinants of health do. So morbidity and mortality are not simply based on infections or other biological reasons, but we know that there are underlying social, economic, and cultural factors, which in turn conditions the biological, physical, and chemical factors so as to cause diseases. And in public health, we call these causes of causes. So COVID-19 has evolved into a worldwide social disease subsequent to infectious diseases such as tuberculosis and HIV/AIDS that are also associated with social factors. And we know that social determinants of health are linked to the prevalence of COVID-19 infection. Moreover, viewed from the consequences of the infection and public health measures, the social effects of the pandemic manifests itself more distinctively in some disadvantaged groups. I just would like to mention a concept by Virchow. So following his examination of a typhus epidemic in Germany in 1848, Virchow, as the father of social medicine, defined artificial epidemics. Virchow, who revealed the importance of social factors in the emergence and spread of epidemics, concluded that despite the biological causality, the underlying causes of epidemics are the problems in political and social structuring, and that disadvantaged groups are particularly vulnerable to both of these problems and the epidemics themselves. In the current COVID-19 pandemic, we clearly see this as most countries are experiencing artificial epidemics among disadvantaged groups, including migrants and refugees. So migrant health should be on the agenda of policymakers and practitioners for a more comprehensive and effective response. because again, we know that physical, mental, and social dimensions of health cannot be separated, and all three dimensions are strongly linked to social determinants of health. So when we come to Turkey and its experience with refugees and other migrant populations, we know that Turkey still hosts the largest number of refugees in the world. So Turkey hosts around 3.7 million registered refugees, and as of April 2020, there were around 455,000 irregular migrants, mainly from Afghanistan, Pakistan, and Syria. According to UNHCR, there were an additional 370,000 asylum seekers and refugees under international protection, most of whom were from Afghanistan and Iraq. So in Turkey, when we look at the healthcare for refugees, persons with temporary protection status and other registered refugees have legal access to public health care. The Ministry of Health has established a national network of migrant health centers, which act as publicly owned primary healthcare centers for refugees living in urban areas. In recent years, the Ministry of Health has employed more than 1,000 refugee health workers who help in decreasing the language and cultural barriers in health service provision for refugees. In April 2020, the Turkish government published a circular announcing that COVID-19 related health services will be provided under emergency services category for free, regardless of registration status, facilitating access to health services for all. According to this circular, every individual who approaches a healthcare center with a suspected case of COVID-19, regardless of their health coverage under the social security system, shall be granted access to testing and treatment free of charge, which was actually one of the good examples in the world. And when we look at the vaccine situation, the national vaccination program for COVID-19 has started in January 2021 with healthcare workers, elderly home workers, and elderly. Registered refugees and migrants have the legal right to access COVID-19 vaccines in the same manner as citizens. And the current vaccination efforts cover registered refugees and migrants. But of course, there are some barriers in accessing those services. So while the right to access healthcare may be guaranteed by legislation, refugee and migrant groups experience several barriers in access to healthcare and to vaccines. These include language barriers, cultural barriers, lack of knowledge about how the health system functions, and lack of knowledge about available vaccines for certain age groups for now, and difficulties in accessing internet, limited number of phone-based or online services in multiple languages, various socioeconomic factors, and of course, the legal status is a huge barrier. So what can we do to improve access to COVID-related services and vaccines? We should be working more on linguistically and culturally appropriate health education and risk communication interventions. We should ensure universal health coverage, including full access to services and vaccines for all, including unregistered migrants. We need more effective outreach approaches, such as working with community leaders, cultural mediators. We can have more hotlines, social media interventions, telemedicine, including mHealth technologies, and mobile services. We also need to close the digital divide and work on decreasing stigma and discrimination towards migrants and refugees. This is also true for the vaccination efforts, because when you want to have a program parallel to the citizens, you really need to work on decreasing stigma and discrimination as well, especially on traditional media and social media. We also need to increase community and of course migrant participation in policy making and service provision. We need to update surveillance systems to monitor the situation of different migrant groups according to different vulnerabilities. And of course, we need to increase intersectoral collaboration for more holistic, interconnected, and gender-sensitive policies and practices for refugees and migrants in the pandemic response. So we know that population groups are interdependent with respect to health, well-being, and peace. So health and well-being of migrants and refugees are not only important for migrants and refugees themselves, but also important for health and well-being of host societies, human and financial resources of host countries, and of course, to build and maintain a peace. So as a last word, considering the inequalities that the pandemic made visible and the artificial epidemics created by human beings rather than the virus itself, all countries need to have a human rights-based and inclusive approach that leaves no one behind to control the pandemic and to promote health at the country and global level. Thank you so much for listening to me, and let me stop sharing.
Thanks so much, Ozge, for this great presentation. It's really reassuring to see the position of Turkey having most of the Syrian refugees as displaced population on the territory and the attitudes that they are taking. So it'll be interesting in the Q&A to try to decipher some of the ways forward in trying to make this approach better, but also how maybe Turkey's example can be used in other contexts, like for example, with the Venezuelans that are in South America. So to continue on this question of challenges, we are now very fortunate to have Dr. Amira Hamadeh. Dr. Amira Hamadeh serves as the Regional Vaccination Program and Medical Movement Coordinator at the International Organization for Migration, or IOM, in the Middle East and North Africa region, also known as MENA, posted in Amman in Jordan. So she joined the organization in 2011 as a migration health physician. Under her current portfolio as a regional vaccine program coordinator, she assists with the implementation of refugee vaccination programs in over 15 countries in the MENA region. She works with IOM country teams to improve vaccination coverage for refugees undergoing resettlement, as well as vaccination training, outbreak response, monitoring, and evaluation activities. She also coordinates the medical movements of refugees who have significant medical conditions who are being resettled from MENA countries. Dr. Hamadeh is a regional master trainer for vaccination and physical examination. She earned her medical degree from Jordan University of Science and Technology and has a master's degree in public health from the University of Edinburgh in the UK. And she will talk to us about the equitable access to COVID-19 vaccines. Dr. Hamadeh, the floor is yours.
Thank you very much, colleagues, and good afternoon. I would like to thank CGC for inviting me to this important topic. Let me see the slides. Yes, thank you. So next slide, please. To give you a brief about the International Organization for Migration where I work. So IOM was established in 1951. It has currently 173 member states. IOM is the leading intergovernmental organization in the field of migration, and it works closely with governmental, intergovernmental, and non-governmental partners. In 2016, IOM joined formally the United Nations as the UN Migration Agency. So IOM calls for orderly and humane management of migration, to promote international cooperation on migration issues, to assist in the search of practical solutions for migration problems, and to provide humanitarian assistance to migrants in need. And this includes the refugees, internally displaced populations, and migrant workers, among others. And among the many IOM activities that are done, IOM promotes for migrants' rights and migrants' health as an inseparable part of the global health and the aim to universal health coverage. Next slide, please. So as part of the organization's support to global health and health equity for migrants, IOM works on improving the immunization coverage for those vulnerable populations, marginalized populations around the world. And this depends on the context in the country and the specific needs. The organization's vaccination efforts span 3 major areas of focus, and these are global vaccine procurement, assisting with improving vaccine coverage and equitable access for migrants and people in crisis, such as the activities that we assist with in the pre-migration health section, and activities related to refugees who are being resettled, and also in strengthening the national immunization systems and participating in immunization campaigns at camps and at the borders. And in 2019, as part of the pre-migration health activities, IOM assisted in provision of around 500,000 of vaccination doses to refugees. Next slide, please. So some might ask why to include migrants in the national vaccination plan, especially now when there is barely enough for the national population. And I think Dr. Ozge emphasized on that through explaining the social determinants of health for these populations. And indeed, to defeat this disease, we need to reduce the transmission as much as possible. Therefore, we need to use the evidence-based approaches in our fight and in our advocacy to target the most vulnerable populations in the country. Only in this way can we actually lower the rates of infection and try to flatten the curve. If pockets of infection remain in the country, then we can't really tackle the issue from its roots, since the virus do not discriminate based on the legal status or the nationality in the country. And for many reasons, as Dr. Ozge mentioned, migrants in these irregular situations are at higher risk for infection compared to nationals, and immunizing them as part of the whole plan is key in defeating the virus in the communities where they live. And because unfortunately, what we see now is that in many countries, some of these groups are neglected when the plan is about preparing the national deployment for vaccination. In this crisis, we have learned that unless we protect every single person, no one is really safe. And therefore, it's crucial for the governments to recognize the public health importance of accounting all categories of migrants, irrespective of their legal status in the COVID national vaccination plan. Next slide, please. And to explore what actually can be done on the ground. As you know, many countries have yet to release their prioritization strategies for vaccination rollout in their territory. So now is the time to advocate to provide access to the vaccine equitably, including to asylum seekers, migrants in irregular situations, forcibly displaced persons, and to use the evidence-based approach in this advocacy at the national, subnational, and international levels. And one way to ensure the access to vaccination for irregular migrants could be that countries not to conduct immigration checks or require proofs for residency when vaccinating their populations. And if you can see in the yellow box, I actually took this as a screenshot from the National Health Services website for UK, where they announced that overseas visitors to England, this is a good example, overseas visitors to England, including anyone living in UK without permission, will not be charged for vaccination against coronavirus, and will not also be charged for treatment or diagnostics, and no immigration checks are needed. So this step might encourage anyone in the country who falls in the priority groups that are announced by the country to approach and register for the vaccination. At this point of time, because we have very limited supply of the vaccine, we are not advocating for migrants to be an indivisible group in the priority plan. Migrants should, regardless of their legal status, be counted and included in each of the vaccine priority groups that are identified by the national authorities in their distribution plan. And to give an example, let's say a migrant who is or a non-national frontline health worker at risk of capturing the disease should be prioritized in the same way as a national frontline health worker in that country, or a 70-year-old refugee who is living in that country should have the same priority and access to the vaccine as a 70-year-old national. Next slide, please. Okay, so as you know, unfortunately, and as was mentioned in the beginning of this presentation, the world's poorest countries continue to shoulder the burden of the global refugee crisis. And it is estimated that around 84% of the refugees around the world are hosted in these countries. And if we leave this fact as it is without thinking of how to equally distribute the vaccination, this will just add another gap in the vaccination distribution. And from here came the COVID-19 Vaccines Global Access Initiative, or COVAX, which is one pillar of the Access to COVID-19 Tools Accelerator. The details of how the COVAX works is beyond the scope of today's webinar, but in brief, this tool aims to provide rapid and equitable access to vaccine for all countries who sign in, regardless of their national income. So it gives an opportunity for low and middle income countries to receive the vaccine at the same time when the high income countries would be receiving it. And so countries that have signed up will expect to receive vaccines for 20% of their populations by the end of 2021, or this is the hope. And to support them in the decision, support the countries in the decision making and ensuring that as many lives as possible are saved, a roadmap for prioritization of the groups has been developed by SAGE, or the WHO Strategic Advisory Group of Experts on Immunization. And if you can look at the next slide. Yes, apologies, this is a busy slide. And I'm sharing it just to show the suggested prioritization groups in this roadmap that was proposed by SAGE. And it depends, it provides 3 scenarios depending on the percentage of vaccine available for the national population in that country. Of course, it's not necessary to for this to be adopted by the governments. The final plan is and the final priority plan is in the hands of the national policies and national laws. So, for example, you see that the suggested when there is only when there is vaccine supply that is enough for 1 to 10% of the national population, the suggested categories are the health workers in the front line and older adults, 65 and above. But when then some more vaccine supply will be available for the countries, more priority groups can be added. And among them are these who are have socio-demographic risks and have healthcare access issues, for example. And here falls the refugees and low-income migrants, asylum seekers, among others. Given that some populations, even with all these global efforts, will not be covered by the global allocation of vaccines, there will still remain a risk for the equity gap. And for that, there are now discussions on the humanitarian buffer, which is considered a last resort to address the neglected or left behind populations who could not receive sufficient vaccines. The buffer would consist of around 5% of the production of COVAX facility, but still there are a lot of talks and nothing yet is announced how this will work. Next slide, please. So in summary, it's important to include all population, all vulnerable groups in the plan at the national level, and we should advocate that loud and clear at all the levels, and to have consistent key messages on the importance of this inclusion, and use evidence-based approach in the fight against COVID. And I would like to end with a statement by our Director General. As he mentioned, it is the responsibility of governments to guarantee that all who are present in their territory, whether nationals or non-nationals, migrants, irrespective of their legal status, have access to vaccines. In practical terms, the pandemic has shown us that nobody is safe till everyone is safe. Thank you. Over to you. Thank you.
Thank you so much, Dr. Hamadeh. This was quite informative, and to remind us that even in countries that have actually done the right thing, which is to consider vaccinating their migrant and refugee population, at what point do they do that in the priority groups? And I would like to re-explore that during the Q&A if there is time. Before we move on to our last speaker, I want to remind everyone who is live that you have the opportunity to also pick the brains of our three experts at the end during the Q&A. So you have a little tab at the bottom of your Zoom screen with Q&A. So please ask as many pertinent questions as you want, and we'll address them at the end. So time for our last speaker now. Ms. Rula Amin is the Senior Communications Advisor at the UNHCR Regional Bureau for the Middle East and North Africa. She leads UNHCR's communications work in the MENA region, which hosts more than 16 million people of concern to UNHCR, including refugees, asylum seekers, internally displaced, and stateless people. Before joining UNHCR in 2017, Ms. Amin worked as a correspondent for Al Jazeera International, based in Beirut and covering Lebanon and Syria. Ms. Amin started her journalism career with CNN in Jerusalem, covering the Palestinian-Israeli conflict in the Middle East. Ms. Amin traveled across the region, and she covered the news for CNN, including from Baghdad, Damascus, Cairo, and Sana'a. As a correspondent for leading international news Al Jazeera and CNN, Ms. Amin covered the region's most critical moments of war and peace, other major developments, as well as the political and social consequences of such major events in the Middle East. She holds a master's degree from Columbia Journalism School, and today she will tell us about the barriers and challenges for equal access to vaccination for refugees. Ms. Amin, thank you for joining us today.
Thank you. And thanks for Columbia Global Centers for always actually giving us the space to highlight the needs of the refugees and giving us the space to have these public discussions that can actually inform all the debate about the needs and how to respond to these needs. I think when it comes to the vaccination, as the UN Secretary General has put it, this is a critical moment. The vaccine equity is the biggest moral test before the global community. And we have all been, using the same line on how nobody is safe until everyone is safe and no one should be left behind. And as the colleagues had demonstrated, it's very important to remember that only when 70% of the population has developed and acquired immunity are we really safer. And as long as we can't do that, we are all at risk, especially with the developing variants of the vaccine. I'm not going to have a presentation, but I'll just share a little bit of some slides to keep you going. I think as UNHCR, who is mandated with protecting the refugees, advocating for them, providing assistance and support and finding solutions, it's one of our most critical moments to ensure that refugees are included within any vaccination campaigns and rollout plans. But as our High Commissioner puts it, Mr. Filippo Grande, he always says, we have to remember that about 86% of refugees live in developing countries. And for these countries to be able to include refugees in the rollout plans of the vaccination and actually give them full access to these vaccination, they need support as well from the international community. And they need support to be able to acquire the vaccines, to be able to administer the vaccines and to be able to respond to this moment in the most efficient way. If you look at the refugees, they are also more vulnerable than the rest of the population in some ways. There are issues, as the colleagues have highlighted, documentation issues. There are protection risks if they're not vaccinated. They could be, of course, in addition to the health consequences, access to services, education, livelihoods and work, freedom of movement, and discrimination. So we have so far got many pledges from many countries that refugees will be included in the rollout plans and they will have access to vaccination. But as we know, many of these countries have not received one dose of vaccine yet. And many of these countries do not have the enough financial capacities and capabilities to acquire all the vaccines needed. Many of these countries have limited and weak health facilities, public health facilities, which actually hampers their ability to administer the vaccines and be able to treat. So the devil is in the details. There are numerous barriers and challenges, but they're not confined to the refugees. They're much more linked to the fact that refugees are being hosted in these countries that are struggling economically. And these countries that have their own challenges. So by addressing these challenges for these countries, by supporting them to overcome these barriers, we are helping inclusion of refugees, migrants, and other groups in the vaccine and to have access to the vaccination. We know that it's not just a matter of having the money to buy the vaccines, as the leader of WHO has put it very well. You can have a lot of money, but it's meaningless if there are no vaccines to be bought. And we know there is a shortage of vaccines. So there needs to be some work done to ensure supplies, to ensure there are enough vaccines. According to experts, there won't be enough vaccines to give to the whole population on this globe until probably 2023 or 2024. What does this mean for these countries? What does this mean for the refugee populations that are dependent on these countries' capacity and willingness to include them? We also know that some of the rich countries are hoarding these vaccines, and this is a major problem. So if we want to sum up these barriers and challenges to ensure that there are enough supply of the vaccines, that there is a fairer way to distribute these vaccines, and that these groups like refugees, like migrants and other groups do have access to these vaccines when they are available. So if we want to dwell on some of these barriers, one of the main issues that I think sometimes are not tackled are the doubts and people's suspicions of the vaccines, the lack of trust in the efficiency of the vaccines. In the rich countries, we are seeing a jump in people's willingness to be vaccinated, in their eagerness, in their registration. But in developing countries, the vaccine rollout plans have not even started yet. A low percentage of people who have faith in these vaccines, and that requires a whole effort that is in addition to the financial issues and to the equity distribution. This means we need to put a lot of vaccines to ensure that refugees, as well as the hosting communities, actually register to get the vaccines. In some of the countries here in the region, less than 14% of an 8,000 refugees that were surveyed said that they had registered. And the rest who had not registered, 77% said they were not sure and they were still thinking about it. And this percentage and these doubts are not different than the doubts of the hosting population. So this is a major barrier and a major challenge we really need to work on. One thing I think what we always also need to be able to address is how do we ensure the sufficient supply? How do we ensure fair distribution? How do we ensure vaccine confidence? We can boost production and improve distribution, but we need to work in the confidence of people in the vaccine and its efficiency. Logistical support is very important. Humanitarian agencies like UNHCR have been putting a lot of effort in trying to support the host communities, the host governments, in upgrading their health capacities in order to be able to administer this vaccine. As we know, delivering this vaccine requires a complicated, complex layer of conditions, including the cold chains, not only from the beginning to the second step, but to the last mile, as we are hearing. So this is a major challenge for some countries that with very limited and weak health capacities. We need to think of Yemen. We need to think of Syria. We need to think of Northwest Syria. These places, not only they have not received a single dose of the vaccine, their health facilities had been badly destroyed and badly undermined and weakened by the conflict there. And they need strong support and meaningful support in order to be able to give their population and the refugee population and the internally displaced people the access to the needed access to the vaccine. So one of the things that people have been talking about and we advocate for as well, because this will benefit refugees, is the cooperation between the manufacturing companies and developing countries in order to increase their capacity. So maybe they can actually contribute to the vaccine supplies and vaccine production. Vaccines must be made available, affordable, and accessible. But how do we do that practically? How do we overcome all these barriers? In some countries where the vaccines had been, the refugees had been included, we know that they had faced logistical problems. For many, we say that the COVID health crisis has evolved into a pandemic of poverty for refugees and internally displaced people. And these people sometimes, when they hear about the vaccines, they have other priorities. They're trying to make their ends meet. They're trying to make a living. They're trying to put food on the table. And getting the vaccination is not a priority. This is something that we really need to work on. Registering on online platforms could be a challenge. Having the means to put yourself in a car or in a bus and get to a health center to get the vaccination is another challenge. So we need to start looking not only on the overall picture of advocacy on the need to include refugees and migrants, but we need to start addressing the actual barriers on the ground, the logistical ones, the barriers that inhibits the hosting countries from administering and giving access to the vaccine for their population as well as the refugees. And they need support. And this is something we try to stress on all the time. The need for the international community to support these countries that host millions of refugees in order to be able to administer the vaccination. Just as a reminder, in a few days, we will mark 10 years since the start of the Syria crisis. And there are more than 6.7 million people who are still displaced inside Syria today. And there are 6.7 million refugees, Syrians, who had crossed the border looking for safety. That are, most of them, 5.5 million, are in the 5 neighboring countries to Syria, in Jordan, in Iraq, in Lebanon, in Egypt, in Turkey. Countries that have their own economic challenges, and we need to stand by them in order to support them so they can include refugees and migrants and other groups. And I stop here to give some room for questions and answers. I hope that able to have some constructive discussions. One thing to remind the viewers with is, we always think when we talk about support for refugees, we always think of donor countries, of big countries, the international community. But the experience we've been having at UNHCR with trying to mobilize every effort. So every individual actually has a role and every individual can contribute. And I stop here.
Thank you so much, Rula. If you could stop sharing your screen so we can all be back.
Sure.
Thank you. Very fascinating discussion, and I feel like we're just scratching the surface.
I want to stop.
From the three speakers, when I was listening to you, Rula, one thing that came to mind is Israel started vaccinating refugees and migrants yesterday, and one of the reasons why some of them have decided to do it is because of the vaccination certificates. So that's at some point in their society, they will not be able to operate like the rest of the population unless they have been vaccinated. Then I think this is going to be another issue that migrants and refugees will be facing. In case of inequalities, it's just the fact that they will not be able to operate in the society, not only because they haven't been vaccinated, because they are missing this proof. So I see that there are very, very many interesting questions coming from the audience. I will get to them in just a second. Maybe just to start us off, I wanted to ask you all three, the role of the host communities and the buy-in. So the example of Turkey, for example, when you are vaccinating the refugee population from Syria, how important is it that Turkish people know that, agree to that, understand the importance? And in countries where there is no host population buy-in, how do you work on that to make them understand basically that no one is safe until everybody is safe?
Thank you, Yanis, for the question. Well, this is actually important for the vaccines as well as all healthcare services and access to other essential services. I believe the key issue is to decrease stigma and discrimination towards migrants and refugees. The second thing is to increase health literacy and, of course, access to reliable health information for all, including host societies. Because when you increase health literacy for all, then people do understand that it's very important that access to healthcare for both refugees and host societies, access to vaccines for both host societies and migrant populations are very important to control the pandemic and of course to prevent other health problems. So I believe policymakers and decision makers have a huge role, academics, NGOs, UN organizations, other international organizations, and also people who are mostly, experts using both traditional and social media tools. Those experts are also very important in giving this message, trying to decrease stigma and discrimination, and spreading the same message that we will be all safe. When vaccines, treatments, tests, everything, health information, personal protective equipment, everything is available for everyone in a country.
Thank you. Dr. Hamadeh, would you like to add something, or Ms. Amin?
I think, yes, Dr. Ozge covered all important parts, and I believe tackling the stigma and the media, the social media, what we hear on the social media, all the rumors and all the misinformations that we have, focusing more on the scientific, factual information, and requiring the influencers in the community at different areas to advocate in their own language, in their own areas of expertise to deliver the correct messages to encourage everyone to buy in.
Ms. Amin, you're on mute.
I think for UNHCR, of course, fighting stigmatism against refugees is one of our major areas of work. But with this pandemic, stigma becomes, on one hand, a barrier, and on the other hand, is a risk, as people may perceive refugees and other marginalized groups as carrier of the virus. If they are not vaccinated, that would enforce such stigma. So that's why we say preventing stigma requires also this vaccinating refugees and including them in all the health response to the COVID pandemic. We have seen this in Yemen, we have seen this in other countries where refugees were discriminated against because instantly people kind of associate them with different ways that may end up excluding them from the health response, excluding them from the vaccination. And as a result, also, when they are not vaccinated, there's that stigma is reinforced. So that's one area of work that we really need to be aware of, and we need to be very sensitive.
So in addition to the stigma, though, wouldn't you expect that there could be some kind of a resentment from the host population? And this is something that Dr. Hamadeh was discussing in her presentation, and I said I would talk about this. So when you talk about the priority groups, the ethical thing to do is to prioritize based on a category and not based on a status. And this is, I think, what Dr. Hamadeh was pointing out. If you are 70, doesn't matter that you're a refugee or a local, you should be prioritized the same way. Yet some countries are going to do it based on the status. Isn't there a resentment that's possible if you are down the line of the priority group in the host population and that you see refugees and migrants getting the shot before you? And how do you try to fight against that?
I think there is that risk, of course, but we also have very good examples. In Jordan, for example, there's been a clear-cut policy to include refugees in all kind of health response to the pandemic, including vaccination. And that did not create a backlash. I think partly because of the generosity of the Jordanian population and the Jordanian people and the government to ensure that refugees are also included. But also there is a realization, I think, and we need to work on that more and more, that if you don't include refugees and if you don't include migrants, at the end of the day, you're not safe. And there will be a spillover. And that comes, that we can also translate that to rich countries and poor countries. Borders do not protect. And this is one lesson we learned from this virus. We are really all on the same boat. And I think that kind of realization is starting to sink in, but we need to enforce it. We need to keep on working at it. Because that's the key critical element, that we all know that even if we got the vaccination, if only 20% of the population is vaccinated, it's useless, because this vaccine will get strong, this virus will get stronger.
And I do hope that, local media, government, communication participate in that message that no one is safe until everyone is safe. Switching on to the questions from the audience. So this is a question probably for Amira from Dr. Parker. In what ways is COVAX involved in the rollout of vaccines specifically for refugees? How could their involvement be improved or augmented?
Okay, so the COVAX, the aim of the COVAX is to distribute the vaccine equally among the countries, among the countries in general, low and middle income countries. One step of the process of signing up to the COVAX agreement is to provide a regional committee with the national vaccination deployment plan. And the role comes to advocate for inclusion of refugees in the national vaccination and deployment plan, to state it clearly in that stage that is going then to the next stage of approval for the signing up in the COVAX. So we need to advocate for refugees inclusion at that step in order to ensure that once the country has the 20% for their population, it means all population and not just the nationals in the country.
Thank you so much for this clarification. A question for Ozge from the audience. So the use of vaccines make the virus more potent. I'll let you discuss whether that's true, and lead to mutations that may render the current vaccines inefficient. Do you think that when we talk about the super importance, quote unquote, of vaccines, that we are just helping the profiteering of medical corporations?
Okay, thank you for the question. Actually, this is of course not related to the migrants and refugees, but we should discuss this for the whole population in countries and around the world. But when we look at existing data, studies that were conducted until now, and of course, based on our medical knowledge, we know that the vaccines actually protect people. And when you decrease the circulation of any kind of virus in populations, then you actually decrease the risk of mutations. So that's very important. We know that vaccines work. Of course, different vaccines work with different efficacies and effectiveness, but WHO says that for COVID-19, vaccines that work over 50% are useful and helpful in decreasing cases and in decreasing hospitalizations, severe diseases, and also we started to see studies showing that it also decreases viral load. When you get vaccinated, then the chances of transmission will probably decrease. We need more data on that, but still the existing studies are promising. And we know by medical knowledge that if a virus circulates in a smaller population, then the chances of mutation is lower. So as we saw in many vaccination campaigns in history for other infectious diseases as well, we need vaccines for coronavirus as well. And of course, in time, with the NPIs, the non-pharmaceutical interventions, with public health measures, and with the vaccines, we will succeed in controlling this pandemic.
Hopefully. So again, you're stressing out the importance of vaccinating quickly and everyone. I just want to point out to the viewer who asked the question that vaccines do not create mutations. Mutations happen naturally. And to prove the point is that the 3 mutations that I discussed at the beginning in my introduction, they all happen before people are vaccinated. Okay, so this is a question for Rula. Why has multilateral governance been unable to obtain or perhaps coordinate advocacy for a waiver in the World Trade Organization? Wouldn't that help to increase vaccine production and supply, and in the long run help ease some tech inequalities across countries? Would you like to take that question? You're on mute. You're on mute. Sorry.
So I'm not sure what is happening at that front specifically. Maybe these discussions are taking place, but it's true. This is a test to someone, I think said this, the COVID pandemic and the vaccination issue is like a stress test to the multilateral system in the world. And it's very true, because what we're facing is a short of supply, a disproportionate way of people acquiring the vaccine. Supply chains are challenging and complicated. And there are some objective issues. It's not all because the other side is not being nice enough. You know, we have real issues here on how to take this, to take these more, we say, you know, vaccinating refugees is not just a moral thing to do, it's also the right thing to do. It's this from a self-interest point of view. But even for people who believe in that, even for countries, hosting countries that believe in that, for them to be able to do so, they are facing severe multi challenges at different layers, and we need to be able to address those. So I think the healthy discussion is, okay, let's deconstruct all these obstacles. How can we help remove some of them? And as it's true, you know, there needs to be more vaccines available for these countries. There needs to be vaccines that are more support to the host government in acquiring them. You know, we have to work on the logistics. We have to work on the supply chains. We have to work on, you know, Dr. Amira probably knows, but it's not easy to have to ensure that there are all these ultra cold chains happening. It's some countries are just not able to provide that. So I hope that all the international rich countries who are capable of helping in so many different ways, not just by providing money and financial support, but even upgrading the health system, providing expertise, you know, are going to be up to this responsibility and will chip in and will ensure that these countries and these groups have access to the vaccine, because it's in the interest of all of us.
Very true. If I may add, I would say that the IP, the intellectual property, is probably not the only reason why there is a production issue. That the actual production capability in low and middle income countries is abysmal. And this is something that we should be working on for the next 10 years. If I am understanding the situation correctly, so in low and middle income countries, you have India with the Statin Serums Institute, who is able to produce the AstraZeneca vaccine. South Africa has some capability, Senegal, but Africa as a whole, Tunisia to some extent, Africa as a whole does not have the capability. And this is really something that we should be working on. So we have time for 2 quick questions. Dr. Hamadeh, again, the role of the pharmaceutical sector. So what do you think is the role of the pharmaceutical sector in ensuring vaccine equity? Due to exclusive rights, scaling up production isn't really feasible, keeping in mind that many of these private pharma companies were publicly funded during the research phase. Would you like to take that question?
Thank you. If I understood, what's the role of the pharmaceutical companies in ensuring the equitable access or equitable distribution
Correct.
of the vaccine?
Yes.
I think this is the time when everyone needs to put on the table whatever effort they can provide, because unless we tackle this globally as one global population, it can't really be solved. So having the scientific basis of the inventions of the vaccines, on developing the vaccines, for example, sharing knowledge with other manufacturers, looking at the bottlenecks altogether, brainstorming as a whole, is very important to ensure that we can produce as many as needed vaccines, because with all the efforts that are happening now, the production is way below, the supply is way below the demand. So I believe, yes, there should be more harmony in and knowledge sharing between all parts of the scientific society.
So the supply is way below the demand, of course, because we need to vaccinate 7 billion people, and these vaccines have just started production basically, and it's actually amazing that they were producing before they even knew that the efficacy was okay. It doesn't help, of course, that countries like Canada, the United States are doing bilateral agreements and are basically hoarding 6 times the population size in terms of vaccines. But I guess this would be another topic. So maybe final question, and I will direct this to Ozge, but if you wanted to interact, that would be okay. So one of the viewers is asking about the passport, the immunity passports. Do you think in the near future this country will start to prohibit the travel of people who are not vaccinated, or vaccinated that are not approved by the authorities? And I will add to that, to make it relevant to this conversation, how is this problematic for refugees if you start instituting these immunity passports?
Okay, thank you. So actually, of course, there is a lot of discussion about these passports and how they can be used, whether it's ethical or not, etc. So we don't know where that discussion will go, but probably, as of course vaccine rollout is in a better situation, then of course people may need to prove that they are vaccinated with vaccines that are approved by certain authorities, including of course WHO. But this won't and this shouldn't of course affect travel. So what we do right now is, if you do not, if you're not vaccinated, then when you travel, then you need to either quarantine for a certain period of time, or you need to again quarantine, and in a few days you need to show that you have a PCR negative. A PCR test that is negative to be able to get out of quarantine. So probably in future, when we have more data about vaccines and their effectiveness in populations, because as you know, efficacy in a lab situation is different than effectiveness in countries. And also, of course, with the variants going on, we still do not know which vaccine is effective with certain variants. So we need more data. We need more follow-up with people. But if in future we will have passports, then probably there will be an alternative way of traveling. There should be, so that if a person is not vaccinated, then he or she should be quarantining, but still he or she should be able to travel with public health measures. And according, I mean, when we think about refugees and migrants, I think it's the same situation. So of course, equity will be very important. Of course, access to vaccines for all will be important. But again, for instance, for resettlement, you know, moving to another country for getting visa or renewal of visas, etc. If we do not have equity for refugees and migrants, that will be an issue in the future as well.
Thank you. Ms. Amin, would you like to add something specifically about refugees and migrants for this immunity passports? You're on mute. Sorry.
It's okay. It's an issue that we need to look at very closely. At the end of the day, refugees are part of the global world and the global village. And whatever measures that are agreed to globally, we will have to consider. But we hope that, you know, the issues and the challenges for refugees, for IDPs, internally displaced people, stateless people, other people who are on the move, that their needs and their challenges to acquire this passport in consideration. And even if these passports are, you know, there's a conclusion and consensus that this is the way to go, that there are exceptions maybe, or there are alternative tools to accommodate the challenges that refugees and illegal migrants and other groups may have, because they don't have these passports. We have to remember, people who are on the move, I mean, a refugee is someone who fled his home because he felt unsafe. People fled their homes, they left everything, they lost their documents, they lost their clothes, they lost their livelihoods, and they are being hosted in countries that are struggling. And many times, documentation, getting their birth certificates and marriage certificates is a major challenge. We try to help, you know, UNHCR, this is a core work for UNHCR, core to UNHCR's work to ensure documentation, because if you don't have your birth certificate and you don't have your marriage certificate and your child is not registered, he cannot be immunized, he cannot travel, he cannot pass a checkpoint, he cannot go to school. So we hope, and of course we advocate, that even when such measures are considered, that the specific situations of refugees and migrants are taken in considerations and alternatives are offered if this is proves to be too challenging for their situation.
Very important clarification.
Sorry, may I add something? I already actually mentioned it, but this shouldn't be, I mean, getting vaccinated or being vaccinated shouldn't be a barrier for travel, especially for migrants affected by, you know, forced migration. And because there are public health measures that you can take, like you know, allowing people to cross the border in case of an emergency or crisis or whatever, and then you know, have them quarantine for a certain period of time, you know, test them and then vaccinate them if you have enough vaccines, because that's what we do right now with other infectious diseases, because not all the migrants, not all the refugees have, you know, measles vaccines or polio vaccine or whatever, then when they cross this border. But when they, you know, go to a host country, then the children or pregnant women or other people get vaccinated in the host country. That should be the approach. So it should never be a barrier for forced migrants.
I want to, Ms. Amin, just let me give the floor to Dr. Hamadeh, who hasn't spoken on that. Dr. Hamadeh, do you have something to add to this?
Well, I think at this point, when the availability of vaccine is very limited, we can't we should not be advocating to have immunization certificates right now, because it would also be inequitable. But looking into the future, when hopefully there will be more vaccine coverage in the communities and the populations, I believe there will be some applications, useful applications for having such measurement.
So you're saying it's premature because obviously almost nobody got the vaccine. So talking about the vaccine,
Yes, so it's inequitable now to have
right.
this.
Well, the example came, from that country that is at 50% vaccination right now, which is Israel. And as somebody pointed out in the audience, who they vaccinate is quite inequitable. So Ms. Amin, would you like to have the final word? You're on mute. Thank you.
Okay. So the last thing is, we always say with UNHCR since the start of COVID, because refugees have the right to seek asylum. They have a right to cross borders to seek safety, and countries have an obligation to receive them. And we always say protecting people against the pandemic and against COVID and other diseases should not be seen as in conflict with allowing refugees and granting them that right. That, as the colleagues had said, there are ways to ensure both, that refugees' right to seek asylum and cross borders is not undermined. At the same time, to take all precautionary measures in order to ensure that there is no further spreading of the virus, and take all what is necessary as the guidelines by WHO. So it's not two conflict things. We can do the two things at the same time.
Thank you for this final comment. So the questions keep coming. Unfortunately, we are at the end of our very, very interesting session. I guess we could have organized a 2-hour session and still be able to go on. But unfortunately, we are at the end of our webinar about challenges and solutions for the vaccination of migrants and refugees. And before handing the floor back to Youssef Cherif, I want to thank all of our panelists for their really interesting contributions. And I want to also, of course, thank all of the people who joined us for this webinar. And I want to thank the 3 CGCs, Tunis, Amman, and Istanbul, for giving us the opportunity to speak today. Youssef, floor is back to you.
Thank you very much. It was a great webinar, as expected, actually. And as we see from the questions, hopefully we will organize other webinars with our colleagues here. And see you soon, hopefully with the vaccine. Goodbye.